Good evening, ladies and gentlemen. Welcome to the Royal College of Surgeons of Edinburgh COVID-19 webinar series. Today, we have a panel from India, Malaysia, and Singapore who will be sharing their experience of post-COVID return to surgical practice. I am Pala Rajesh, the Vice President of the Royal College of Surgeons of Edinburgh, and it is my pleasure to introduce Professor Pabnendra Lal, who is the Director and the Professor of Surgery from Maulana Azad Medical College. He is one of our esteemed international surgical advisors and has helped the college for the past decade and a half in organizing the MRCS examinations in Delhi. Welcome, Pawan, this evening. We have Mr. Sivakumar Krishnaswamy, who is a consultant cardiothoracic surgeon in the University of Malaya in Kuala Lumpur, Malaysia. He completed some of his training in the United Kingdom in the West Midlands Deanery. And I'm proud to say that Siva was an exceptional student who secured the highest mark by any trainee in the European Board of Cardiothoracic Surgery. It still is holding at the present time. And we have Mr. Harish Mithran, who is a consultant thoracic surgeon at the National University Hospital in Singapore. He's a training program director in the National University Health System and is an examiner for cardiothoracic surgery, the Joint Surgical Fellowship exams, which are held alongside the University, the College of Surgeons of Hong Kong and the Royal College of Surgeons of Edinburgh. I would personally like to thank all you gentlemen for taking the time and making the effort. I know it's almost 2 a.m. for Siva and Harish and almost midnight for Pawan, but thank you very much. I'd like to start by requesting Pawan to share his experience with going back to what is now called the near normal. Thank you, Pawan.
Very good evening, Mr. Rajesh, and to everyone from here at New Delhi. And thank you very much indeed for giving me this opportunity to share the experience from India. I bring greetings from my 2 institutions. One, the National Board of Examinations, which is one of the largest single organizations conducting exams in the country. Nationally and imparting DNB training, and the other my institution, Maulana Azad Medical College, where I hold my unit in general surgery and minimal access surgery. So greetings from India to everyone, and thank you once again to Mr. Rajesh and to the college for this very kind invitation. So at the outset, I would like to tell you the COVID scene as it stands today on the 24th of August. We have about 3 million cases confirmed as of now. We are the 3rd largest country behind Brazil and the United States. But thankfully, the death rate has been much lower than the international levels. It stands at about 1.8 to 2%. And the recoveries has also been substantially good at about 65 to 70% of the population. The testing had been very low, as I can show you here. The testing rates for the diagnosis of the COVID scene has been almost 1/8 of the countries like the United Kingdom or the United States. But it's been picking up fast, and it's keeping pace with the numbers that the country has seen. And the graph here shows how the country actually started very low, and during March 26th to the end of May, actually, that was the lockdown period. And you can see we were very, very good at that time. It really shows there. And just about when the lockdown opened up, beyond June, it just started skyrocketing. And we now have about 70,000 cases on an average every day. The latest stats showed 71,000 since yesterday. So it's been increasing. The pockets in the country have really been densely affected at some areas. But the good news is that at many cities where it had peaked, it has started coming down. So just to keep the timelines in perspective, it was on the 24th of March that the government of India announced a nationwide lockdown, which was for a total of about 70 days. And from the 1st of June, the country started opening up. And fortunately, this gave time for the health authorities to gear up with their infrastructure and evolve strategies. During this time, also, there were clear directions from the government as well as from surgical associations, which mandated suspension of routine surgeries through several advisories. And emergency surgeries also had a serious dip during the peak times. And then slowly, as it became inevitable that emergency surgery had really no option but to be continued, it did actually continue. And in this regard, I would like to mention the role that the Association of Surgeons of India played through its president, Dr. Raghuram, who is also an esteemed fellow of the college, which through multiple sources in the media, several meetings through the media, and interactions with the government, was able to bring about a lot of awareness amongst our country. You know, we have a vast country where the surgical practice is between the public and the private sector. And it was very important to, inform that what was to be done and what was not to be done. And that came through the advisories from the association. Also, some of the good advisories that we were able to follow during this period of lockdown came from the SSO guidelines, which we were able to, use, categorizing our patients into the 3 categories where the surgery had to be done because they were high risk or life-threatening, or where they could be postponed because of their low risk, and they came into the category of elective work. And the expert panel, which our surgical association came up with to simplify it for the ease of understanding of our general surgeons in the country, working into the interiors, was to classify the surgery into these 5 heads and ensure that we follow only the emergency and urgent surgery during the peak of COVID and postpone all the rest for a later date. The Ministry of Health and Family Welfare of Government of India also very proactively came up with guidelines and categorized the risk areas to safeguard the healthcare providers, classifying the zones where there was mild risk or moderate risk, and what kind of personal protective equipment were to be used so that we could deliver the emergency surgery and at the same time give safety to our healthcare workers, the surgeons, anesthetists, and all the paramedical staff that are there. Aerosol generation of the surgeon has been a contentious issue, and it continued to get debated even in India. There were contradictory claims, recommendations from the Center for Disease Control suggested use of enhanced respiratory devices rather than the N95 level for aerosol generating procedures. There was American College saying that there was insufficient evidence against or versus open and laparoscopic procedures. And then there were more studies which came in, which from the SAGES from America, which said that filters could be used to decrease the aerosols during laparoscopic and robotic surgery. But all in all, during this time, throughout April and May, and in the good part of June, elective surgery was completely suspended in the majority of the country. And therefore, only very few centers were actually doing emergent surgery related to obstructions in malignancy and other emergency surgery, but most of it only started in the latter part of June and in the month of July. And there were many debates happening between the advantages of open surgery, which had the advantage of lower aerosol generation at the cost of having a longer hospital stay in the hospital with much more contamination, versus laparoscopy, where there was advantage of lesser contamination but higher aerosol generation. And so this debate between the three types of procedures has been raging. And in the country now, at this particular time, both open and laparoscopic surgery has actually started in both emergency and elective procedures. As I see the way forwards, I think the guidelines that the association made for the help of our surgeons has been to stagger the surgeries, reduce the number of healthcare workers in the operating rooms, use the necessary personal protective equipment, and all the other protections that are required to be used by the healthcare providers. So as we see getting back to work, I would say that we would need to use various guidances that have been coming to reduce the exposure of the healthcare workers, and at the same time keeping our patients safe. And one of the most effective principles that I found, and which we have been using, has been from the joint statement released by these four associations, which said that there should be a sustained reduction in the rate of new COVID-19 cases for at least 14 days whenever we are starting with elective surgery procedures. And I think that is the key, which we are following now in the country, that if we see a decline in the 2 weeks period, then is the time that we would need to start with elective surgery. And the facility should have obviously appropriate infrastructure of ICU and non-ICU beds and adequate personal protective equipment. It also provided for the necessary essentials that the facilities require to manage and diagnose COVID-19 patients, and to use these protective equipment not only before surgery but during and after surgery, including the follow-up period, with adequate care to the healthcare providers, and continue the necessary testings beyond the time of surgery as well. Now, India has peculiar challenges. It has got public sector on one side and private sector on the other side. And we have got various kinds of hospitals in the public sector, from very, very small units providing in the primary health care and the community health centers, down to the district hospitals, which are 100 to 200 bedded, and then larger medical colleges, which are 500 to 2,000 bedded. And on the other hand, the private sector, which has a single unit nursing home, and it can go up to a private large hospital. The problem of segregating the patients, the COVID patients from the non-COVID patients, has been a problem, and still is not allowing many of the bigger hospitals to get started. I wanted to point out here that two big medical colleges in the capital city of Delhi, that is my own medical college, Maulana Azad Medical College, and the other larger medical college, the University College, are closed till date. There is no emergency and no elective work, no teaching going on except COVID, because they are the COVID hospitals for the capital city of Delhi. Now, that's been good and bad about it. Good has been that it got centralized and it got managed in a more organized way for the city. But it has completely damaged the entire surgical workload and other patient care for these two institutions. We have more than, between the two, more than 2,000 medical students and more than 500 postgraduate students whose research work and all other work has come to a complete standstill. So while there was an attempt by the government to contain and manage COVID, on the other hand, there was a complete fallout with certain institutions coming to absolute standstill. And I am in one of those with zero elective and only emergency surgery being done. There have been other models where have been partial COVID care, like All India Institute of Medical Sciences, or parallel COVID and non-COVID in most of the private hospitals. As the lockdown opened up, the patients started coming in much because they were needed. There was no surgery and no treatment done for the previous 3 months. And so there was an absolute backlog, and they all rushed to these private hospitals or any other hospital providing any kind of care. Conducting examinations during this time has been very challenging, and I must say the leadership that the National Board of Examinations took, we were able to conduct OSCE-based, webinar-based examinations and practical, and this was in one subject, it could go up to 40 centers through webinar connection nationally. And we were able to use the examiner pool in these various centers with 4 examiners going at every center and not more than 10 or 12 candidates at one center. And using this modified method of exit examination for the 18 subjects, we were able to, till today, complete exit exams for 2,500 candidates, which I think during this period is a record of its kind. So I think this is the way we will need to move forward. And to conclude, I would like to say that resumption of working and coming back to work during COVID-19 and beyond has to be cautious and guided. It has to be with a very thoughtful approach, with due care and caution, and a lot of careful planning. Safety of patients and healthcare workers will have to be kept in mind, because COVID-19 is going to be here with us, and we are going to be getting used to be working with it, alongside it, and maybe how long it continues will be anyone's guess. But I would say that we will need to get used to this new normal. We might need to stagger the elective work despite economic challenges for the private sector, and continue to provide emergency and semi-urgent surgery. In my opinion, starting slowly would seem to be better than going full steam, and a tailored approach to individual hospital circumstances, because every hospital and every institution will have its own limitations. And we should be wary of generating publications for surgery in the times of COVID, which is another new trend that I've seen. A lot of work being done on pushing how many are you doing in the emergency surgery and how many electives have you done with COVID. And see, there are so many parallel papers being made. I think one needs to be a little bit careful about getting into that, getting pushed into this kind of a research work. And with that, I would like to thank the 3 great institutions. I owe my gratitude to the National Board, where I'm currently working as the director, Maulana Azad Medical College, the place where I perform my surgery, and of course, Royal College of Surgeons of Edinburgh, for which I have been an examiner and have been hosting exams for the past 15 years. Thank you very much, Mr. Rajesh, for this kind invitation. Thank you.
Thank you ever so much for such a comprehensive and exhaustive overview of what has been happening in India. I'm sure there will be some questions coming through the Q&A chat box. I can already see 4 of them. Please, the participants in this evening's webinar, please keep the questions coming, as we would want a fairly lively discussion at the end of the presentations. I would like to now request Mr. Sivakumar Krishnasamy to provide us with what Malaysia has been during this time. Thank you.
Thank you, Mr. Rajesh. Sorry, it is getting through the slides. Thank you, Mr. Rajesh, for this opportunity. And I'm Mr. Siva, cardiothoracic surgeon from University Malaya, Malaysia. So I'm just going to talk a little bit about what has been the situation in Malaysia, the impact of COVID-19 on our surgical services. What did we do that in terms of prioritizing our cases, the timeline of events that happened for us over here, and what we did in University Malaya Medical Center, where we actually became a COVID center ourselves, and how is it returning back of services in the new normal era. So a bit of the introduction. Now, COVID-19 took us all by surprise. We were actually not ready. We thought something that happened in Wuhan would never happen over here, and everybody was like their normal life, leading everything in terms of practice and all. But it gave us a sudden different adversity and changes, and we suddenly had to come with a term that I think Prof. Pawan was mentioning, the new normal. It gave a big impact worldwide, nationally, locally, for all surgical practices and services. In Malaysia, we had our first lockdown, which is called the MCO, from the 18th of March. Then later on, that became a control movement control order, which was started from the 4th of May till the 9th of June. And from the 9th of June, which is basically on the 10th of June, we had a restricted movement control order. And that is going on till the 31st of August. And we don't know how will it be after the 31st of August. Government is yet to say anything. So this is something from the intercollegiate slides on COVID-19, which we adopted in our center and generally in most of the hospitals in Malaysia. We categorized cases into emergency surgery, planned surgery, the usage of PPE, the theater distribution of staff. Now, we did ban laparoscopy during the initial phase of our MCO, and of course, endoscopy was only done for emergency procedures only. All aerosol generating procedures were kept under close watch and were not allowed without proper justification. Now, then we had the prioritization. Now, what we did basically is we had a COVID OT team, and that basically became the center in terms of how we prioritize our cases. We had everyday meetings to decide on which case should be done, and the problems we had were all highlighted. So we had a COVID-19 surgical pathway and how we had to handle the patient post-operatively. All electives were cancelled during that time. Our main problem for cardiothoracic surgery was mainly shortage of blood. And in fact, in the Ministry of Health, there were centers where the staff had to be shifted to other hospitals. So in Malaysia, we have got three major working forces. One is the Ministry of Health. Then we've got the Ministry of Higher Education, which is the universities that provide the service. And of course, the private sector. Private sector hospitals were not designated COVID hospitals. However, all state hospitals were made COVID hospitals. And in the Klang Valley region, it's the Sungai Buloh Hospital, which became the main center, it being the infectious disease hospital. Then we have got the General Hospital in Kuala Lumpur, and of course, my center in University Malaya. So these three major hospitals were made as the COVID center hospitals in Klang Valley, and that has made us, in terms of the staff, to provide our routine services being paused. And we had to actually basically incorporate a lot of COVID-like practices into our current practice. So it's the same message all over the world. We had to maintain emergency surgery capabilities. We had to protect all our surgical workforce and also fulfill our alternate roles. We were playing more of administrative roles during this time, and of course the non-surgical roles. So this was a paper, which came out in New Straits Times. In Malaysia, we found out that as of May, there was almost 28 million of surgeries cancelled globally. And of course, that is worldwide, a staggering, shocking thing. And for us, basically in Malaysia, this is what had happened to us. COVID-19 was declared as a pandemic on the 10th of March. And we basically went into lockdown on the 18th of March. In UMMC, all our elective OT and clinics were stopped a week later because it was taken us by a sudden shock. All emergency services continued. We were basically a hybrid COVID hospital because we have got one of the largest number of ICU beds in the country, almost 40 beds for the general ICU. We restarted our semi-elective OT and resumed partial clinical services on the 10th of April. Now, semi-elective OT were basically semi-urgent cases where the cases cannot be postponed for more than a month. So we all had a joint meeting in the OT COVID committee meeting, and then we select the cases And this was a multidisciplinary selection. It's not prioritized to any particular specialty. And we resumed back all our elective OT on the 5th of June onwards. So for us in the Department of Surgery, we worked actually as a group. We forgot ourselves as cardiothoracic surgeons, upper GI surgeons, vascular surgeons. We all came under the banner of Department of Surgery. And then we outlined ourselves in terms of how we were affected, what has changed for us, how did we adapt to these changes, what did we do in bringing this change into our service and practice, and how we sustain in moving forward. So for Department of Surgery, we came up with a few guidelines. We had Annex 14 in terms of management of COVID-19 patients. We have got all these workflows here with videos. And of course, we run liver and renal transplant. And that is the Annex 22 in terms of how it has to be run during this time. Of course, all elective transplant works were paused until the 6th of June. And this is our workflow that we had for one of the appendix in terms of how a patient would come and how they would be seen by the anesthetic team and how the preparation would be, the donning and the doffing, and how things would move along for standardization for all staff in all disciplines and specialty. So basically what we did is we drew up protocols, guidelines, and workflows. I think that was done worldwide in every hospital, in every institution. We decanted patients to other non-COVID hospital because we became a COVID hospital itself. Creation of Department of Surgery COVID OT Task Force. We managed the OT list and human resources as a whole as one team itself. We manage our resources, the PPEs, the blood products, the ICU capacity. In fact, my cardiothoracic ICU was also converted into a COVID ICU. Emergency OT services, and we resumed semi-emergency elective OTs slowly. It staggered up. We canceled all our surgical clinics in the early phase and reinstated partial clinic to full clinical services after the 6th of June. Of course, there was new SOPs that we had to follow. Healthcare workers were all screened and staffs were kept safe during this time. We clustered our teams and on calls in provision of surgical services that were needed. Now, our main platform of interaction, it's the same like everyone else worldwide. We use Zoom, Google Meets, or Team. And our research and education, we had a bit of challenges in the initial phase, but I'll be highlighting in shortly how we delivered the teaching for those. Now, full elective OT services was resumed back from the 5th of June onwards. Semi-elective was done during the lockdown based on priority of cases, and that was started during the second phase of lockdown, which was the second week of April onwards. Now, when we talk about returning back of services in the new era, I divided it into three main areas for us. One was the clinical service, one was teaching activities, and one is on research. So for clinical activities, the problems we had was we were unprepared. We were overwhelmed with the healthcare issues in many centers. There is, of course, no cure or vaccine today. Social distancing as a new norm. We got to consider the vulnerable group among our clinical practitioners itself, and of course, the shortage of blood. So what we did was how we overcame this to return back to normal. All cases are discussed in advance, at least 2 weeks before. All the patients were brought in 2 days earlier. They had to go through a swab. For all elective surgery, emergency service ran as usual, but decanting happened for surgery that has potential need for blood transfusion. And that was mainly cardiothoracic and vascular cases. We had to send to other centers for the first 2 MCOs. Now, after the second MCO, work was done slowly to reinstate back to basic service in cardiothoracic surgery, where we got back our CICU and also our OT. So we started off first with coronary cases, which all couldn't wait. And of course, pleural-based procedures were started, followed by lung cancer cases, which already had a delay of around 5 weeks during this time. So we had 62 cardiac cases and 5 thoracic cases that needed postponement during the lockdown period. And what impact did it give us? We had 2 cardiac deaths in our coronary cases that were postponed. Fortunately, nothing in the thoracic cases, and all thoracic cases were operated the first thing as all elective services were resumed. And we were also fortunate none of these cancers were upstaged. As of today, all cases going for surgery needed COVID swab. Now we've brought it down to 1 day before because our amount of regions that for swab has been underutilized, and the lab is able to process it within a day. So they say now we can admit the patients 1 day before rather than 2 days. And we use cell saver for all our open heart surgery cases to limit our blood transfusion. Now, in terms of teaching activity, what have we done? Being in University Malaya, my role is not only as a clinician, I've also got my role as a senior lecturer. So we teach undergraduate and postgraduate. Now we started back all our teaching activities via online platform from the 18th of May onwards. and that was via Microsoft Teams. We initially had 2 seminars per week, 16 seminars in total. This is for the undergraduate program. And once the students were returned back to the campus, which was started on the 13th of July, all the clinical teaching in the new norm where the students were divided into 7 students per group, but we further subdivided them to 3 and 4 students for bedside teaching. And that was again with following to all the SOPs that needed to be done. And of course, we conducted our first end of posting on the 7th of August via OSCE platform. For research, of course, we also have got postgraduate students and our master students. So we had online teaching for them, an online meeting for all research team. Clinical research until now has not yet started. A lot of research work are going on audit-based and data collection. Lots of COVID-19 related suggested studies, but however, during this time of difficult economic situations and all, there's been a huge problems with grants. And in terms of Malaysia, how we have fared in COVID-19, of course, our numbers are not as big as what has been in the States, India, or even many parts of Europe. We've got until to date about 9,400 cases with about 125 mortality. However, being a small country itself and our health system is mainly public, we have to strategize and how we distribute our cases and how we resume back our work before going on full steam. So we have not let our guards down yet. We are still being cautious, but at the same time, we are also aware postponement of all our elective cases also has an impact to patients. Postponement of the educational programs have also had impact to our students. And of course, the research work has always been an issue, and that will be an ongoing issue. So all our previous practice has to be changed according to the new SOPs. We have to learn to live with this new disease, and we all got to return back with new guidelines and new SOPs. With that, thank you. This is a scene from my OT with my anesthetic, preparing to induce one of my open heart cases. And thank you from Malaysia.
Thank you ever so much, Siva. That is, again, a comprehensive overview from the time you were struck with the Wuhan virus, as you called it, to what you are presently. And I see that you have a very structured strategy on how to deal with it, with the medical workforce, the clinical services resuming, and the research. So, it'll be very interesting to see how this going forwards, how this evolves, and it may be a message to other similar healthcare environments in the region. So thank you. And I see that questions have been coming in. Pawan has been answering them. Keep it going, Pawan, and we'll also have a robust discussion when we finish Harish's presentation. Thank you, Harish. Welcome from Singapore, and I hope we can learn from your experience in Singapore as well, as we know that you guys took care of COVID right from the beginning, but you also had a second spike.
Yes, we did. Great. So, well, good evening to everybody in the UK. Good morning to everybody in Asia. My name is Harish. I'm a consultant here in Singapore in National University Hospital. So I'm just going to talk about our experience, how we went through our COVID practice, how we went through our COVID and how we're going to return to our surgical practice. So just to get everyone up to speed, we have about 5.7 million people in Singapore, and we picked up about 56,000 cases since the COVID started. So this is the case summary in Singapore as of just yesterday. We currently have had 54,000 that have been discharged, 2,000 are still active, 2,000 over in the community facilities, or what we call the isolation hospitals or isolation camps, I would say that. And also 76 of them are stabilized. We've got no one in critical care right now, and we've had 27 deaths so far. And if you look at the swab tests that we've done in the country, I think almost about 30% of the country has been swabbed already. 1.7 million of us have gone through the swabs. So, how did it all start? So basically, I just got to go back to the beginning. So we actually experienced SARS in 2003, and that was actually very, very severe for us. So when that happened, the government of Singapore came out with the DORSCON system, which is actually disease alert system. So they divided it into green, yellow, orange, and red, of course. So when things started to happen in Wuhan, in China, we actually already alerted, the government actually put it up on on the yellow alert already. So we were already told from a hospital setup that you guys got to get prepared very, very early. And so that's exactly what we did. But what happened was the numbers, as countries started locking down, we also started to see more and more patients with COVID. And one of our biggest area where we found out was actually from the hostels, or from we have a lot of foreign workers who work in construction in Singapore, and they are placed in the hostels, and we found a large group of them actually there because they actually live in a very closed environment. So that spiked the volume of cases up there. And so we then went to what we call the lockdown, which is about 2 weeks after Malaysia did. So we locked down on the 3rd of April, and we unlocked, or we went to the second phase on the 15th of June. So when we went to lockdown, or when we were in the yellow zone, we were already told that you need to plan resources. So what was very important is that we made sure that we distributed our workflow. So from the hospital setting, we had to divide everybody according to all levels. So we always had the senior leadership, consultants, junior manpower, and then we put our clinical or administrative staff actually on home leave, and we set up the home computers for them where they can access the system through their homes, and they can access some of the certain systems within the hospital. What we did was we then categorized our teams into A, B, and C, where we divided each team that way. And initially, we wanted to do it on each day of the week. And you can see here from this list was either inpatient, operating theater, and clinics. We found out a bit too taxing to move people around. So it ended up becoming Team A doing inpatient wards for the whole 2 weeks. Same thing for Team B and outpatient clinics. So the outpatient clinic team was more of the what we call clean team. So in case, say, a Team A got infected, then they would go on 2-week break and 2-week quarantine, and Team B will take over, and then that team will then have to break down into smaller groups. So that's how we set it up. And of course, the inpatient wards, we didn't allow any visitors. Any patient who was symptomatic had to get 2 COVID swabs negative before being let out into the normal wards. If not, the initial phase, they were sent to the National Center for Diseases. And then what happens was, being in National University Hospital, we were a tertiary center. So we, on a daily basis, at least for thoracic surgery, how I can speak of, we get referrals from 2 or 3 other hospitals within. So we always had to make sure that those patients actually got 2 COVID swab tests that were negative before moving over. This is to ensure no cross-contamination between the hospitals. And we actually needed to get approval from the CEO and COO of the hospital before before the patient could get transferred over. This is for them to understand what was the movement between the patients and hospitals. So, of course, inpatient surgery, just like any other country, we stopped all elective surgeries, but we still went ahead with emergency trauma. Cardiothoracic surgery still went ahead, obstetrics still went ahead, and cancer patients actually still went ahead. And the reason for this is because you can see that this is just from a thoracic point of view, but we actually had different capacities, and actually we were, as you can see, we were overwhelmed by positive cases, but we weren't overwhelmed by the ICU load. So many patients didn't get admitted to the ICU. They were more in isolation and they tested positive. So we actually still managed on an extended capacity also. So most of our cancer cases were still being done at that time. But we did postpone the other elective cases, and for like GS, all the hernias, all the orthopedic surgery cases, all of them got postponed. And we were ready to move on to, in case the ICU started getting filled up, and we would then decide on each case accordingly then. So outpatient clinics was, of course, completely restricted, was cut down a lot, only 1 visitor at a time. and everybody had to be screened. At the same time, what we did was we moved to teleconsulting. So not a big group of them, but at least I would say maybe about 30% of our patients were teleconsulted. We either postponed them or we actually called them up and said, look, how are you feeling? We've looked at your scan or your CT scan, or we looked at your x-ray that you did somewhere else. And if you're well, you don't need to come in. So that's what we did. And of course, all meetings and conferences were postponed completely, and we actually moved straight away to Zoom meetings. So unlocking the lockdown, basically what we had to do was, now that we're moving into the next phase where we feel that we have got less and less amount of infections in Singapore, we need to now prioritize who do we do surgery and how do we then get back to the norm again. So firstly, before we from the hospital point of view, nationwide in Singapore, what we do is everybody has compulsory mask wearing. We have very strict contact tracing, and I'll show you how it's done. And hospital and visitors, you can see this is like a sign in the hospital over here. We only have 2 visitors at any one time during 12 to 8 p.m. In the outpatient clinic, only one accompanying patient. They have to register through contact tracing. And you can see here, denied entry, those who are unwell, those who are on quarantine orders, stay home. And the last one, everyone in Singapore has to wear a mask. If not, they're going to be heavily fined. So this is the contact tracing. So you take your phone, you just scan the QR code, and it'll be automatic once you have done it once or twice. So basically, we know exactly where you are, where you've been. So if there's been a COVID outbreak in a certain area, they can actually backtrack it very easily. And so in the hospital, from our point, is like, what was the right timing to unlock this lockdown? So we had to make sure that the timing was right, so the cases were low within Singapore. We had adequate testing capacity already ready to go. We made sure that we have enough beds available, hospital beds. We ensured we had enough isolation rooms ready, and we ensured we have enough ICU beds ready and ventilators ready. And of course, we have enough PPE for everybody in the hospital. So you can see today's papers. I just took a snapshot of it. We had 51 new COVID cases in Singapore, 1 in what we call the community, and 7 imported. So people who came back from overseas, we picked up 7 of them. And the rest, the other balance was, like I mentioned to you, is coming mainly from the dormitories. And so when did we decide that we're going to unlock it? Actually, it was basically when we actually screened, I think, 99% of the dormitories. And then we figured out that was our biggest cluster. So once we screened them already, then we decided to go into opening. So at the same time, our workforce, we can't just say, let's start the theaters again. And what we did was our staff nurses all were deployed to different hospitals. Once we know that the volume of load within the hospitals have reduced, so our staff nurses are coming back to the hospitals, our technicians, our perfusionists, our junior doctors, and some senior doctors were deployed, but not from surgery, but from other areas. So once everybody comes back in, and this is going to start on the 1st of September, where we can actually go back to a normal workflow again. So we're going to do that on the 1st of September. It's going to go back to normal team-based system. In the OT, we'll still have to maintain exactly what we did for COVID. We have specific OTs for COVID patients. The anesthetists have to always wear N95 masks during intubation. We have to wear N95 masks and PPE for all infective cases. And of course, we got to make sure that if any patient is symptomatic or has a flu, they get 2 swabs negative before they can proceed to the operating theater. So again, going back to the unlocking the surgical lockdown, is we follow this kind of system depending on our capacity. And of course, lastly, the outpatient clinics. So again, we're trying our best to get into telemedicine in Singapore. We don't have a very high pickup rate, but we're still getting there. But within the hospital, we tell all the doctors to reduce per session to 30 patients per session. You can see here, each seating is labeled, so they make sure there's a gap between the patients and whoever's around them. And on top of that, our meetings right now, we are basically, if we start our meetings again and you want to meet face-to-face, limited to 5 people per room. However, most meetings now and teaching are done on Zoom. And of course, one good thing that has come out of COVID was that we actually managed to get our whole Singapore, Malaysia, and Hong Kong back together with Siva, and we do regular teachings for the FRCS sessions every Saturday at 3 to 4:30 p.m. So I think we are definitely moving forward to a lot of Zoom meetings and stuff. So this is what the setup is when people come into the hospital. They get registered. Everybody is lining up over there. There's actually markers everywhere in Singapore. You see this 1 meter distant markers for lining up. Lots of photos and reminders around. And this is how it looks like when patients come in to get registered. So with that, I'd like to thank you, and that's our experience so far in reopening.
Thank you very much, Harish, again, for a very comprehensive overview. I noticed that a lot of the questions were directed towards Pawan, and he has effectively answered all the questions. I wish to, open the discussion session with some questions which I would like to pose personally. The first one is about training. Pawan said that training had come to a complete standstill. And over this period of time, the trainees have lost their clinical experience. Now, in the UK, the trainees were deployed after some rapid training into the COVID areas. And what we've said is that the experience during the COVID period will be considered, because there are other areas of training which they would have picked up. They would have picked up some medical training. They would have picked up team working, communication skills, etc. To be in a position to, if you like, accept what they've done and not say it was totally out of context, because ultimately we are all doctors. We may be training in a variety of specialties, and it depends on the year of training as well. So what has Malaysia, Singapore, and India done to try and help these trainees, and how do you think you will be in a position to accept some of their experience during this time? And how would you go about helping them when they get back to their clinical arenas? Because in the UK, some of the people who are in a research position, some of the people who are out of program, but had to come back. And when they came back, they had to get into a clinical situation. So, Pawan, you put your hand up. Can I ask you for your comments, please?
Yeah, thank you, Mr. Rajesh. I think I gave a wrong message if I said that the training was coming to a standstill. What I meant was training in the specialities came to a standstill. Of course, all the residents in the entire country were the COVID warriors, managing all the patients, and still are managing. And so all the specialities and their residents got together into a general rota in the hospital. And that is how these services are being delivered. So in my hospital, which is a 2,000-bedded hospital, we had at one time 1,100 COVID positive patients, and chock-a-block ICUs, entire ICU with 152 ICUs were completely full. And all of these patients, and everywhere in the entire country, I think the whole credit for managing them it goes to our resident doctors who are the trainees of various departments together. So one needs to pay a lot of big thanks to this huge workforce without whom we would not have been able to manage this. But what I meant for the standstill was the training in their own specialty. So we in India, in contrast to the UK, have a very short training period for the Master of Surgery or, let us, if we were to just contain ourselves to surgical discipline. And in out of 3 years, crucial 5 or 6 months is a huge time loss. And some of these were in the areas in which they do their compulsory research work, which is their thesis work. And all the research work also came to a complete standstill. And we teachers are all trying to grapple with this reality, because this has been obviously an out of the world experience for all of us. I mean, none of us had faced such a situation in our lifetimes. It's been a war of kinds, and obviously we would need to evolve training strategies to overcome that. And one of that which we did was to start webinars very early on. And in fact, the lockdown in India started on the 24th of March, and we started rolling out our webinar classes from the first week of April, both for the undergraduates and for the postgraduates. So I think the country has risen up that way to the requirements of the teaching, but we are just trying to grapple with the hands-on clinical practice, and which I'm sure will start coming back. But whatever has been the time loss of 5, 6, or 7 months is going to be kind of would have to be made up, by more intensive work in the remaining time. I do not see any extension being given to these trainees, but it still remains to be seen what regulations will come in. And we are evolving methods to give hands-on training to them through various modules which we are trying to develop from the national board, where we could inculcate some surgical training through certain box trainers, or hands-on skills-based exercises that we could give in small groups, where they are able to do it under video conferencing or a webinar control with the trainer. And we're trying to evolve this because we still are uncertain what kind of shape and what time this whole pandemic takes. The graph, whether it is going into a plateau, or it does come down, or we see a second peak coming back again. It's really unpredictable, and so we couldn't just keep waiting for it to go away. We would need to develop strategies. And as I mentioned with the national board, we used the OSCE questions which we were used to for the MRCS, and I was one of them since I was knowing it from the very beginning, from 2010 when we rolled out the first MRCS in Delhi. I was quite used to this, and so we were able to get our examiner pools in various other subjects to design OSCEs similar to those in surgery, and we were able to roll it out in the whole country very effectively, with hands-on actual practicals being held for the candidates, with 4 examiners physically located and 8 candidates there, meaning maintaining social distancing and all the other precautions. So it was possible, but it is pretty challenging and pretty heavy on the faculty requirement. For rolling out 40 centers with 4 examiners, we needed a pool of 160 faculty in the whole country to do it in one day. So I think we will need to evolve strategies and work around this as we emerge from this pandemic.
Thank you very much. Both Harish and Siva are in a system which is very, very close to what we have in the UK, with progression on an annual basis, and they have ARCPs, and we have this formative assessment leading to a summative assessment in the end. I wonder whether Siva and Harish have got any views on how they dealt with the trainees who are moving from year 3 to year 4 and year 5 to year 6, especially the candidates who are going to be ready for their JSF examinations in cardiothoracic surgery. How are you trying to see how you can help these candidates, progress? Are you going to allow them to progress by way of their formative assessment, the workplace-based assessments, DOPS, and things like that, and their previous experience? And as Pawan says, with simulation, and webinars, do you think you will be in a position to safely get these candidates across, or do you think you'll have to wait for the examination process before you can get them across?
Okay, I can answer that for Malaysia. Okay, so for Malaysia, we have got basically many specialty programs that is going on. But the one that has come up with a very standard and fixed guideline is the general surgery exam. So the general surgery exam, what they have done is they have basically considered the last 6 months where the candidates were supposed, the final exam supposed to be in May, to be null and void. So they have given them an extension of additional 6 months where they're going to do the exam in October. And that has given them this additional period of time to pick up once we resume back our service in June, to do whatever rotational posting that was paused during the lockdown, or whatever hands-on experience, and also whatever thesis work that has not been completed to be moved on. So that time extension was given. However, saying that for cardiothoracic, nothing has affected in terms of their training, in terms of their rotation. So most of them who have been stationed, like in my hospital, where they were supposed to move out to another general, to either Serdang or IJN, they have been kept in University Hospital and they have not moved out to another center. They are currently preventing movement between hospitals, especially if it involves out of state. So they've been stationed back in the same place. So the same team, the same group of consultants, and we just, once we started resuming our work back, the hands-on experience and everything was moved on. But one thing, as Harish mentioned earlier, a good initiative actually started off by Harish somewhere in late May, where we started off the joint FRCS teaching between Singapore, Malaysia, and Hong Kong. And we do it every Saturday afternoon, and it was being moderated currently by various consultants from these 3 countries, and we get their trainees who are going for the exams to prepare based on topics. And I think that has been very good, and it's been a formal way of, one is assessing their knowledge, and 2, also getting them to be, in a way, preparing for the exams, at least with a timeline of scopes of topics that can be covered. I think probably we are going to early next year, right, Harish, if I'm not wrong. Yeah. So that's what's being done. And we've got journal clubs done every Saturdays for the Malaysian counterpart for cardiothoracic, and we do that just 1 hour before the FRCS joint teaching. And that has also been going fine. And in between, we do get some webinars being organized by industry, and we do give some talks in between for that. But in terms of phase-on-phase courses, like this year for the KL review, we are not having it. We probably will be thinking for it to be done next year, depending again on the travel restrictions. And hands-on, I think there's no restrictions as of now once we have restarted back our service.
Thank you. A specific question with cardiothoracic surgery in perspective. I've heard from your colleagues here in the UK that patients who were ventilated early on had adverse outcomes. And then we understood that it wasn't ARDS, but it was endothelial dysfunction, and really putting them on a ventilator is not a good idea. And the critically ill patients who went on to ECMO had an unacceptably high mortality. Now, what has been your experience with ventilation in both Malaysia, Singapore, in the cardiothoracic, arena?
Okay, the experience for COVID for us, fortunately, has not been much. In Malaysia, in my center, we have not put any patient on ECMO. Mm-hmm. But in terms of ventilation-wise, majority of them were on non-invasive ventilation. So they were being put on BiPAP and some amount of CPAP support. But the group that went into ventilation, the outcome was, I would say, mixed. The younger group somehow or other did pull through. The elderly group, some did not make it through. But we have got 6 intensivists who are totally dedicated to this in my hospital. They took charge of the ventilation and they took charge in full management. So our role as a cardiothoracic community in my hospital was minimal for that. We were only kept or told to be standby if a patient needed ECMO, and we didn't put anyone because we if that came about, we will have an MDT to decide. And I mean, we will never call for any. And until today, fortunately, none of them have gone into ECMO.
Thank you very much. Thank you very much. Harish?
Our side, actually, we've had 2 patients put on ECMO, and we've been very successful with both of them. So one was a 65-year-old and one was a 55-year-old or 50-year-old. One's a male, one's a female. The male came off ECMO after 12 days, and the lady probably after about 10 days. And they were long stays in hospital. They stayed for about a month after that. But both of them came out on the newspapers, and it was a big joy, for us to save them and get them out of it. So our experience has been good about it. And again, like I said, we are very good intensivists. So a lot of the management was actually done by our intensivists. And they did a great job over there.
Excellent. Thank you very much. You see, now we've all talked about we need to increase our throughput. And Pawan was saying that, we need to make sure that, when we get back, we must get back slowly, with caution, and get up to speed. Now, is that going to affect trainees? Because in the UK, the backlog has been enormous. And the belief is that it's probably going to take a couple of years to get back to where we were. And during that period in time, the same workforce, no increase in the workforce, the same workforce who are tired because they've been working really hard in the front line are the people who are going to have to carry on and try and make sure that this backlog is cleared. Now, is this going to be possible in your environments?
Can I answer the question about resident training, at least in Singapore? I think it's actually benefited them more with the COVID situation. Because we went into, for cardiothoracic per se, we actually went into teams. And so when we went into teams, there was one team just dedicated to the theater for 2 whole weeks. And so all they did was operate. Yes, it was tiresome for them. Yes, they didn't, they had 2 cases a day, but we even cut down our cases. So we didn't do 4 cases a day like we always do. We did 2 cardiac cases, and we'll have 1 thoracic case. So, and there are 2 separate theaters for that. So they actually got much more hands-on. In fact, the logbooks got filled up a lot faster actually than normally if they were in a team-based setup. So on the training perspective for cardiothoracic in Singapore, I think it increased more than actually decreased. And how we actually divided it when we were on lockdown for about, from April until now, end of August is 5 months. And how do you divide it between cardiac or thoracic? We said, okay, we'll cut it in half. So everyone gets 2.5 months clockwise to your cardiac posting and 2.5 months clockwise to your thoracic posting. And you look at their numbers, it's amazing. I was like, wow, this is it's much faster actually, faster achieving when it's a team-based. When it's a OT-based setup, and then 2 weeks later they get the clinic experience.
So you've got a model now to carry on, to increase your clinical practice through your trainees, because your trainees are probably getting more operative room exposure than they did in the past.
Absolutely.
So, gentlemen, thank you ever so much. It has been revealing. It has been interesting to hear the perspectives of 3 different countries. We've gone past time. We managed to answer most of the questions. If there are any more questions, we'll see whether we can answer them and send them into the YouTube channel. And I'd like to personally thank Professor Lal, Mr. Krishnaswamy, and Mr. Harish Mitran for having taken their time off in these, late hours of the night and early hours of the morning. Thank you ever so much once again on behalf of the Royal College of Surgeons of Edinburgh. Anyway, you guys are part of the college, so thank you. Thank you very much.
It's a pleasure.
Thank you very much. Thank you very much, Mr. Rajesh. Thank you. It was a pleasure. Thank you.
Absolute pleasure.
Thank you, Mr. Rajesh. All right.